morning or good afternoon, everyone, and welcome to Decoding B11, your guide to DSI compliance. My name is Lynn, and I'm the Campaign and Field Marketing Manager at Drummond, and I'm here with three of my colleagues, Brenda, Eric, and James, who are going to introduce themselves in just a moment. Together, they will discuss the transition from A9 to B11 in great detail. You can use the chat function on the right-hand side of your screen to submit your questions, and we will get to them at the end of the presentation. This webinar is being recorded, and you will receive a copy of the recording in the coming days. With all that being said, I will pass it over to James, Brenda, and Eric.
Thank you, Lynn. My name is James Threatte, and I am the Test Lab Director here at Drummond. I've been in this role for 2 years with a total of 5 here in the Test Lab. I started out in health IT in one of the first clinics doing paperless records, and then co-founded a specialty EHR. Among other things, I led a team to get our product ONC certified, and then came over to Drummond to do ONC certification for others. I've been on both sides of this now, and my goal is to help my customers get certified with less hassle and frustration than I experienced. I also want to introduce Eric Herrera, who's been with Drummond for 6 years, starting with the Test Lab as an intern and then as the account manager for the last 2 years. He has a software development background, and we look to him as our technical expert. Eric has played a key role in creating and maintaining the knowledge base, Proctor sheets, test tools, and other Drummond resources over the last few years. We also have Brenda Millet, who just celebrated her 3-year anniversary at Drummond, capping a 2-decade career in health IT and interoperability. Brenda comes to us from a large EHR vendor where she excelled in compliance and product management. She has also led teams to achieve and maintain ONC certification. So let's begin today with Brenda, who can tell us about the B11 functional requirements.
Thanks, James. So for those of you who are aware, the HTI-1 final rule was brought into effect on March 11th of this year, and it's really the first set of regulations that introduces artificial intelligence into the healthcare and EHR space. The HTI-1 final rule introduces the new B11 decision support intervention criterion, which replaces the time-limited A9 criterion. And it's really the first time that the A9 criterion is being revised since it was first introduced back in 2012. Developers who are currently certified to the A9 criterion must update to the B11 decision support intervention criterion and provide that functionality to its customers by the end of this year, so December 31st of this year. The B11 decision support intervention criterion introduces 2 types of DSI, evidence-based and predictive. Evidence is largely a carryover from the A9 clinical decision support criterion with some new functionality that's been introduced. Predictive has really drum up quite a bit of confusion and discussion, and many of you have come to us asking, do we really need to provide the predictive decision support functionality? If we don't currently supply predictive DSI, do we really need to comply with all of the B11 requirements? Are we exempt? So lots of questions and confusion around the predictive, and we'll get into some of the details about the requirements there. But the term supplied by it becomes a key factor when determining what is and what isn't required when we speak about predictive DSI. ONC has been very clear, indicating that EHR developers are not required to author, develop, or otherwise provide predictive DSI. However, developers are required to provide some mechanism or door for their customers to enable selection of a predictive DSI, possibly a self-developed predictive DSI or some other third-party, other parties' predictive DSI solution. And one more common implementation that we see for this is the G10 EHI provider launch functionality. So developers who are currently certified to the G10 criterion can use this functionality, which simply looks like a button within the EHR user interface that users can launch to launch a new browser tab or some other third party's predictive DSI. Next slide, Eric. So what is predictive DSI? Predictive DSI, ONC has defined it as technology that supports decision-making based on algorithms or models. They derive relationships from training data and then produce some type of output that results in prediction, classification, or recommendation. There are a number of different technologies out there and functions out there that meet the definition of predictive DSI. But some of the more common examples that we see in the healthcare space are really those models that predict maybe a given image, predicting and identifying a malignant tumor, perhaps, models that predict patients that are at risk for sepsis or possible readmission, and models that even gather or document or draft up clinical decisions, so clinical notes, where the provider can decide what clinical notes and what content actually makes it into the patient note and the EHR. So all great examples of predictive DSIs and things that meet that definition. Next slide, Eric. So you may still be wondering, okay, what exactly does my EHR need to do in order to meet the B11 requirement? Is required to enable your users to support, configure, and manage the decision support interventions. Users must have some method or mechanism of selecting and activating both evidence-based and predictive DSIs, whether you supply them or not. Users must also have the ability to record and change the source attribute information. And we'll get into some details about that. Recording becomes important when those customers decide to use a self-developed predictive DSI to be able to record such source attribute information. Users must also have access to complete up-to-date source attribute information in plain language descriptions, meaning not in codified form, so you shouldn't see any SNOMED codes or LOINC codes, etc., for both evidence-based and predictive DSIs. And for evidence-based specifically, the ability to provide electronic feedback. So users must have some mechanism, a way of capturing feedback data for the evidence-based decision support interventions that are triggered, and the ability to export such feedback. And we'll go into a bit more detail about that in just a minute too. Next slide. So when configuring or enabling a DSI, what data does the EHR need to be able to make available to the users? There's certain US CDI data elements within the EHR that need to be made available when an evidence-based decision support intervention is triggered in order to provide that patient context. So you can see those 8 US CDI data elements listed here. And for predictive DSI, all US CDI data elements must be made available. And you can use a combination of these. And you'll notice that some data elements are US CDI v3 specific. So you're only required to, at minimum, support the US CDI v1 elements until the end of next year, until US CDI v3 becomes the baseline. Next slide, Eric. So what source attribute information must the EHR support? All health IT modules must, who are certified or attest to B11, must support source attribute fields for both evidence-based and predictive DSIs. There are 13 source attribute fields for evidence-based and 31 source attributes for predictive DSIs. This does not necessarily mean that the certified health IT developer must populate the content of that source attribute, those source attribute fields, if they do not supply the decision support intervention. If you supply it, then therefore you will be required to provide up-to-date content for that source attribute information. But again, EHR developers must provide some method for users to record the source attribute information as necessary. Next slide, Eric. So here are the 13 source attributes for evidence-based. You can see the carryover from the A9 clinical decision support criterion, the first 4 source attributes that are listed, and the introduction of the new 9 new source attributes for evidence-based, and there's 9 of them, 8 data elements and 1 data class. And again, if you do not currently support the US CDI v3, you don't necessarily have to support that until it becomes the baseline. Next slide, Eric. As part of the evidence-based decision support intervention requirements, ONC has defined evidence-based DSIs as those that are actively presented during the clinical workflow. They help to enhance, inform, and influence decision-making related to the care a patient receives. And it includes, but is not limited to, any interruptive alerts, such as medication alerts, order sets, icons on a clinical dashboard, and even clinical calculators. So the feedback loop must be supported for evidence-based DSIs. And ONC was not prescriptive on how or when the feedback should be captured. Users can decide, or developers can decide, when that information is captured, either during the clinical workflow or post hoc, after the fact, via an application if they wish. That feedback must be made available to a specific set of users to be able to access and also export that data if they wish, in a computable format. And that can be done using the same format that was used for the B10 EHI export criterion. And that feedback must include, at a minimum, the intervention, the action that was taken, the user feedback if it was provided and if it's applicable, user, the date, and the location that the patient was seen at the time. Next slide, Eric. So as I mentioned, there are 31 source attributes for predictive DSI. Those fields must be supported by all EHR developers who wish to attest to the B11 criterion. If you do not currently supply any predictive DSI, you are not responsible for populating those fields. However, you must give your end users the ability to record such information and change it as needed. And provide that information. That information must be provided in plain language descriptions and obviously not in codified form. For developers who do supply predictive DSI, at times those predictive DSIs will need to be evaluated for effectiveness, appropriateness, and validated, and therefore that information may not always be available. Therefore, developers must indicate when such source attribute is not when that information is not available. And users must have the ability to add additional source attributes in addition to the 31 that are required if necessary. Next slide, Eric. So for those developers who do provide predictive DSI, for each predictive DSI that you do supply, you must implement and provide an intervention risk management practice that includes risk analysis, risk mitigation practices, as well as governance. This ultimately is just going to build transparency and accountability for the predictive DSIs that you supply, and helps users determine whether the PDSIs within the EHR are fair, appropriate, valid, effective, and safe. ONC was not prescriptive on any type of framework that should be used for those intervention risk management practices. However, developers can reference the NIST AI risk assessment framework as a starting point, and the recently released ONC DSI resource guide references some additional guidelines and best practices that can be referenced. Upon attestation, developers will be required to provide a public hyperlink to those intervention risk management practices, and as part of your maintenance of certification and assurances, you will be required to review those risk management practices on an ongoing basis. And Eric, in a few minutes, will take a deeper dive into that. Next slide, Eric. So for those developers who wish to update from the A9 criterion to the B11 decision support intervention criterion in order to maintain compliance with the ONC-based EHR, you must register your product via the Drummond customer portal by November 1st. And submit your attestation no later than December 1st of this year, so that it gives our certification body ample time to update everyone's ONC chapel listings by the December 31st deadline. So Eric's going to take a few minutes now just to take a deeper dive into some of the implications of the B11 decision support criterion that it has on the G3 Safety Enhanced Design report, as well as the real world testing requirements.
Thank you, Brenda. So the next item on the agenda for today I want to talk about a little bit about is the B11 conditions and maintenance of certification requirements. This first kind of assurance is more general and applies to kind of all certified criterion under the program. But the condition states that a developer must provide an assurance that it will not interfere with a customer's timely access to interoperable health IT under the program. And there's two ways that this directly applies to the B11 DSI criterion. The first one, as Brenda mentioned earlier, was maintaining compliance to base EHR. In order to stay compliant with the new base EHR definition that begins on January 1st, 2025, developers that are currently certified to the A9 clinical decision support criterion must update and provide the new B11 decision support intervention criterion to their customers by the end of the year deadline, December 31st, 2024. Second way this directly applies is with regards to the standards updates. As was also mentioned, USCDI version 1 is minimally required to attest to B11 by the end of this year. But as part of the HCI 1 final rule, we will be incrementing that baseline to USCDI version 3. So developers that are certified to B11 at the end of this year, leveraging the USCDI version 1 standard, would need to update and provide the expanded USCDI version 3 requirements by the December 31st, 2025 end of year deadline. The next maintenance of certification requirement is more specific to B11, and it also kind of is broken up into two parts. The first one directly applies to all certified health IT developers at the time of your initial certification and kind of on an ongoing basis from that point on. You must ensure that your health IT module includes comprehensive and up-to-date plain language descriptions of your source attribute information. So as Brenda mentioned earlier, plain language kind of refers to language that users can easily understand and use because it is clear, concise, well-organized, and also accurately conveys information. And the regularly reviewing and updating of the source attribute information is vital for maintaining users' trust, accuracy, usage, and safety in your health IT systems. And this proactive approach ensures that all developer-supplied DSIs remain reliable and effective. The second condition applies directly for B11 certified health IT developers that are supplying predictive DSIs. The compliance states that you will have to continuously update your intervention risk management practices as necessary, whether you're adding in new predictive DSIs or removing them. The risk management practice would need to be updated accordingly, and the summary information that is publicly posted and was submitted to the cert body would need to reflect those changes as well. This monitoring and updating of the intervention risk management practices also ensures broad transparency and enables users, patients, researchers, and other interested parties to understand kind of the steps that you as a developer are taking to mitigate any risks associated with any of the DSIs, predictive DSIs you are offering. The next conditions of certification that applies for B11 is real-world testing. So first, just to clarify, real-world testing is not the same thing as live testing. As it was mentioned earlier, B11 is purely attestation-based. No live testing is needed. But what real-world testing is it aims to verify that your health IT meets the needs of end users in an actual clinical environment versus kind of the controlled conditions that we go through as part of our initial certification testing, self-testing. But B11, again, is now eligible for real-world testing. So all health IT modules that are certifying to B11 would need to include this in their upcoming plans. Developers that certified to B11 before the August 31st, 2024 deadline or cutoff date will be required to include B11 as part of the upcoming 2025 real-world test plan submission that is due in our portal by November 1st of 2024 of this year. Otherwise, if you certified to B11 past the September 1st, 2024 cutoff date, B11 would need to be included as part of the 2026 real-world test plan that won't be due until November 1st of 2025 next year. For those developers that are looking to get ahead of the curve, we would recommend including the A9 clinical decision support criterion as part of this upcoming real-world test plan that is due in this November. And this, could be potentially beneficial for you just to get an idea of what measures you decide to ultimately choose for B11 and to get a round of the real-world testing under your belt before it is required. Next, we want to talk about the inherited certified status that applies for the certification program. This is more of a disclaimer. If you are looking to increment your version number to include the B11 certification, then ICS testing, inherited certified status testing, may be required if your listing is being inherited for the 4th time. If you have any questions or concerns on where you currently stand, or any other questions or comments on your status, would highly recommend reaching out to your account manager and or the certification body. Last final note here is also for the upcoming real-world test plan submission that is due November 1st of this year. If you certified the B10 at the end of last year, you will need to include B10 in this upcoming plan submission. Next, I want to talk about the B11 Safety Enhanced Design report requirements, otherwise G3. But before we talk about B11 specific suggested tasks, I want to talk a little bit about G3 from an overview perspective for anybody going through this for the first time. So G3 is more commonly referred to as usability testing, and it's aimed at enhancing health IT to meet the needs of your end users. Requires developers to devise a set of tasks for each applicable criterion that requires G3 as a required dependency for your participants to demonstrate. Requires a minimum of 10 participants per task whom contain the occupation and experience that align with the capability under test. It will then require you to report on usability metrics that detail the participants' overall success and error rates, average time to complete a task, task path deviations, and overall ease of use rating. All this information will be compiled and submitted as part using the NIST 7742 report template and ultimately posted onto the chapel. However, as the criterion name alludes to, safety enhanced design testing also has a central focus on patient safety, and therefore your report itself should contain some risk assessment details for each of the tasks under test. We recommend having 2 types of risk assessment, pre and post-test. Pre-test risk assessment could be you as a developer reviewing all the tasks and making a designation to see which task you think poses the most risk to patients. Conducting the usability testing, and then post assessment could you reviewing all the tasks that the participant tested on to see what ultimately poses a risk. It's good to have both because preconceived ideas may or may not actually be borne out as you're conducting the usability testing. As I alluded to earlier, all the information in the NIST 7742 report would need to be publicly posted onto the chapel. There's a lot of granular data, and ONC is looking to standardize that information and has provided the chapel SED guide that contains kind of allowable standard formats and allowable values that we're looking to that allows the data to be parsable and standardized. So the chapel SED guide is detailed in our G3 knowledge base article. So for any developers going through this for the first time, I would highly recommend taking a look at our knowledge base article. A lot of valuable information, and as well as a list of suggested tasks for all other applicable certification criterion, as well as our knowledge base also contains our SED report manager, which is where you as a developer would submit all the required SED components necessary for certification. There's data entry, SED report, PDF that needs to be submitted, and you can manage that all in our customer portal. But circling back to the centralized focus of this discussion today, talking about how SED testing relates to B11 DSI, developers, attesting to the new criterion would need to assess kind of the user-facing functionality gaps between the requirements of A9 and B11, and as necessary, update their current SED into a singular and complete report that includes what was previously done as well as our suggested list of tasks. So next, talking about B11 specific suggested SED tasks, we've broken this up into 3 kind of points. So first off is evidence-based DSIs. as Brenda went through the functionality requirements, these SED tests kind of reflect what she went through. But to start things off, for the most part, a lot of this is carried over from A9, but there are additional data elements and source attributes that could potentially be tested as part of this updated SED testing. But starting off through our tasks here, a user should, select any an evidence-based DSI using any of the required data elements, either alone or in combination. User should also then record, change, and access the source attribute information for that evidence-based DSI. Next, a user should trigger an evidence-based DSI and then access the source attribute information for that triggered evidence-based DSI. If B2 applies to your certification listing, then it is recommended and suggested that a user triggers an evidence-based DSI using incorporated problems, meds, and allergies data elements from an incorporated transitions of care or referral summary file using your B2 functionality. Lastly, for the evidence-based SED task, we recommend including users to provide the feedback data for a triggered evidence-based DSI, as well as ultimately providing the export feedback data in that computable format that is required. The next set of tasks that we've broken up into is for the user supplied predictive DSIs, as it was mentioned earlier by Brenda in the functionality requirements. Developers don't need to supply predictive DSIs, but need to be able to open up a door or have a mechanism to for users to add in their own if they so choose to. So this SED test reflects those functionality requirements. Users should be able to select that predictive DSI, their own user supplied predictive DSI, and leverages the required USCDI data elements. Users should be able to record, change, and access their own source attribute information for that user supplied predictive DSI. And then next, the user should trigger the user supplied predictive DSI, as well as access and review that source attribute information for that triggered predictive DSI. This last slide here is noted as optional, and this is optional if you are, again, choosing not to supply predictive DSIs, but it will be required if you are choosing to supply predictive DSIs. So this set of tasks mirrors kind of the user supplied predictive DSIs. Again, a user should demonstrate selecting of a developer supplied predictive DSIs that leverages the USCDI data elements. Users should record, change, and access the source attribute information for that developer supplied predictive DSI. Next, the user should trigger the developer supplied predictive DSI, as well as access and review the source attribute information for that triggered DSI. Next, I want to talk about some recently published updates we've made and resources we've made on our customer portal, starting out with our B11 checklist. So just circling back, we did update our B11 knowledge base article before we started this webinar today. Now include some FAQs as well as our B11 checklist. The B11 checklist is similar to what we provided for the B10 last year, the EHI export. It's just a checklist that's designed to assist you as a developer to understanding all of the DSI requirements that you will be attesting to by the end of this year or moving forward. Next, I want to talk about the attestation form. With the new final rule, HCI 1 final rule, there was updates across the program made that include, attesting to minimum standard code set updates, USCDI version 1 and 3, as well as the new DSI criterion. So what you'll see, well, first off, if you're wanting to take a look at the Word version of this form, we have a copy of it available in our portal. It's the required attestations and document knowledge base article. What you see on screen here is our online version that will only be assigned and made available after submitting a new registration in our portal. So as Brenda mentioned earlier, we would recommend submitting that registration by November 1st. That way you can attest by the 12/1 date, so we can have you published by the end of the year. But the first kind of significant update you'll notice here is we no longer will ask you for a conformance method version number. Instead, we will ask you for the date internal testing was conducted in order to verify conformance. But diving deep into this B11 attestation specifically, you'll see it first starts off with a conditional checkbox to whether your developer does or does not supply predictive DSIs. If you check the does supply predictive DSI, then some conditional fields will be populated where developer must attest that the product indicates when source attributes are not made available for review, as well as the conditional field for you to supply the summary information URL that's going to be publicly posted onto the chat ball. If you are not supplying predictive DSIs, you would simply check the box and continue attesting to the general requirements detailed in the document that include all the functionality requirements that Brenda went through earlier. And at the very bottom, again, you'll also see that USCDI version 1 or 3 can be selected. Next, I want to talk about, as Brenda had also mentioned earlier, as promised, ONC recently released their B11 resource guide. And this resource guide will provides a little bit more details and clarifications on the B11 criterion, as well as contains a few extra examples of technologies and functions that could and could not likely meet the definition of predictive DSIs. So I would highly recommend taking a look at this as well for another valuable resource. The resource itself is made available in our B11 knowledge base article, but if you go to the B11 certification companion guide, you'll find it under the applies to entire criterion, the very last bullet point. Next, I will pass it back to Brenda to talk about how B11 could potentially help you with B11.
Great, thanks, Eric. So as Eric mentioned, over the last couple of weeks, months, Drummond has feverishly been updating all of its guides and resources to make available to you. So one of those being the new criteria selection framework, which you're all probably familiar with. It includes the new B11 criterion, along with the criteria dependencies for B11 decision support interventions. As Eric mentioned, we've updated the B11 checklist and made that available, which includes all the functionality requirements, similar to what we did with B10 and G10. And we have an updated G3 Proctor sheet that includes all of the new SED tests that Eric just went over, and those are all available on the Drummond customer portal. I highly encourage everyone to sign into the Drummond customer portal, take a look at the knowledge base. The knowledge base articles have updated information regarding all of your interoperability criteria that were affected by the HTI-1 final rule, along with the new B11 knowledge base that Eric mentioned, and your ability to contact the support team here at Drummond. And we will do our best to field the questions that you have and clarify any of the requirements regarding HTI-1 along with the B11 criterion. So definitely sign into the Drummond customer portal for that. Over the last couple of months, James, Eric, and I have done a number of check-in calls with all of our clients that have been affected by the HTI-1 final rule, as well as the transition from A9 to B11, giving everyone an opportunity to really ask questions, give further feedback on some of the requirements, and really just an opportunity for you to meet with your account manager and get to know them a little better, and just using them as a point of reference and contact here at Drummond. So I encourage you, if you have not had a check-in call with your account manager, please reach out to them, have a quick call. You can also contact the support via the knowledge base and customer portal as well. Next slide, Eric. So this was a big year for Drummond. We celebrated our 25th anniversary, and we are proud to say that we're built on a foundation of unwavering impartiality and expertise. We are not just known for our ONC testing and certification services that we provide. We have been providing for over 20 years HIPAA compliance validation, healthcare penetration testing, along with comprehensive healthcare risk assessments. And more recently, our FHIR client app certification and full matrix interoperability testing as well via our new Fireplace platform. So take a look at that. And more recently in industry news, you may all be very aware that there are some cybersecurity concerns in the industry. But this isn't new to Drummond. We've been doing this for well over 20 years, including penetration and vulnerability testing, ransomware readiness assessments, and more recently, the AI risk assessment that can be applied to the B11 criterion. And we've You may or may not have already been exposed to our advisory services, the Health IT Compliance Guidance. Some of you may have used these services for G10 compliance as well as B10 EHI export. Certainly, we have a wealth of options available there with regards to B11. So feel free to reach out to your account manager and we'll put you in contact with the right folks here at Drummond to give you more information on those services. So ultimately, we want to be your compliance partner, and we have those services available for you if you so wish to seek some more information on those services. So at this point, we will open up the floor for questions, and we'll introduce James back into.
Great. Thank you, Brenda. And thank you, Eric. That was wonderful and informative. I know we've been working very hard on getting clarifications on lots of things and trying to better understand and put our advice in writing. And so our knowledge base does now have the B11 checklist on the B11 page. Notes that there is no B11 Proctor sheet. ONC has restricted us from calling it a Proctor sheet because there is no official test procedure. So it is a B11 checklist, and that checklist does have the attestation form language, the suggested SED tasks, the functional requirements of B11, as well as some other notes and info that would be useful to developers working on B11. I'm going to go through the questions and try to answer what I can. But definitely, if you have questions after this webinar, reach out to your account manager, whether it's I or Eric or Brenda, and we can absolutely set up a meeting or just go through your questions as needed. Because we do want, we realize that there's a very short deadline here to get this done. And so we want to make sure that, we don't have customers with issues at the last minute. So our first question, we assume that any actual source attributes used in DSI should be noted, not just the 13 listed. For example, allergies and meds are source attributes, but not listed in the 13. So the 13 source attributes are for evidence-based, and that is to show there's 4 actual source attributes and then 9 demographics and other details. Those only need to appear if they were considered and used for that evidence-based decision support intervention. For evidence-based DSI, though, there are 8 types of data to be used and considered. Now, most of those are carried over from A9, but there are 2 new ones, which are procedures and implantable device. Those 8 data classes are the ones that need to be available for evidence-based DSI, whereas predictive DSI is going to be all US CDI data elements available. And that covers the second question too. For evidence-based, you don't need to make all US CDI data elements available, just the 8 that are specified. But for predictive, you are going to use all the US CDI data elements. You can add more if you want. There's no restriction as long as you meet this minimum baseline. Next question, if PDSI does not interact with all US CDI data elements, how would that be documented? So we've gotten this question where people have asked, is provenance really going to be used for a DSI, or is this or that going to be used for DSI? Unfortunately, the way that the rule is written, developers are attesting that they support all the data elements being used for DSI, and there is not really a pathway to request or to get an exception to any of those. So I know some developers wanted to hold off on some and focus on other data elements, but when it comes to sign the attestation, that you're attesting to supporting all of it. Next question, would AI and large language model used to listen and generate clinical note and map coding and background not used to predict or suggest be considered predictive DSI? And so I don't believe so. I think that that's something that is outside of the health record, and it's not using patient data to make a prediction or suggestion. So, so no, that would not be an included DSI. Are users required to have the ability to edit source attributes for vendors supplied DSI? Yes. If so, how does that work with the maintenance and certification requirement to keep the source attributes up to date? This is another one that we've gotten, and vendors can work on that the way that they see that they best. We can only really comment on the certification requirements as far as the real world implementation and what to do when XYZ happens. Would be better asked to ONC, or I know that there are consultants out there that can help with things like that. If a company uses 10 plus AI systems under the hood, do they certify each, or do they submit for one certification at the portfolio level? So the health IT module that a user, and in this case it would be a provider user, whether it's a support personnel or the provider themselves, as well as hospitals and their users. So the health IT module itself certifies. They don't certify separately each PDSI. Those will be, their risk management practices summaries will be posted on the URL for all 10 of those, but there's no distinction on how many or which one DSIs are included in the B11 certification. All right, risk assessment, is that required for the addendum, or if we have completed the report, or do we need to supply for all measures previously documented? I believe this is referring to SED. So the risk assessment practices are not in there. Is not in the suggested SED tasks, since that's not something included in the user workflow. So these suggested SED tasks that you'll see in the B11 checklist, these were ones that we discussed with ONC and went back and forth a couple of times. And so these are the suggested SED tasks. Now, we cannot require these SED tasks, but if an SED is submitted that does not have these tasks, we're going to have to take a closer look. And, we would really hate for someone to have to redo the SED, especially at the last minute. So please take a look at those suggested tasks. You can add more or change them, but the idea is that all the user functionality included in the criterion is tested for usability and risks to patient safety. Is G3 also required for B11 attestation? Yes, G3 is a required dependency for B11 attestation. And a G3 SED report must be submitted along with the B11 attestation. I think there's another question like that. Are you including the privacy security dependent criteria, even though ONC erroneously left those off the HTI 1 final rule? Or are you waiting until that is corrected in HTI 1.2? So our documents only describe the rule as it stands right now in law. At a later date, if things like that are updated or corrected, then we will modify our documents accordingly. But that is something that has been a surprise for people, that there are no D criteria or privacy security criteria that are dependent for B11. And so there's no audit log or any of those other requirements included. Can you provide a functional example of the selection door for enabling their own PDSI? So ONC hasn't prescribed what that looks like or how that works, but G10 certified systems have certified a functionality called EHR Provider Launch. And EHR Provider Launch is a valid approach to create that door to enable user-sourced PDSI. Please confirm whether SED testing can be approached as a gap-style test and can focus on just the new requirements, meaning that the ability to configure implantable device and procedure DSI needs to be tested, but not the entirety of the original date elements that were not changed. So since this is self-attested, developers obviously need to attest that they support things like that, implantable device and procedure. We encourage all developers to self-test the entirety of the criterion and to confirm that they are, in fact, compliant. And also to retain that documentation of their self-testing in case of audit at a later date. There are lots of carryovers from the A9 clinical decision support as far as SED testing and tasks goes. So ONC did say in the resource guide that they're not required to redo anything that was previously done, but that's only if the user interface has not changed. So if something has changed, then you'll need to take a look at that and make sure that it doesn't affect the results from the SED from last time. So that would allow them to skip suggested SED tasks like the incorporate and reconcile CCDA, and then generate or trigger a DSI based on problems, meds, and allergies. Things like that can be skipped as long as it was done before and the functionality has not changed. But there are numerous things with evidence-based that are new, such as recording and changing source attributes, leaving feedback, exporting feedback. So developers should take a look at our suggested list for all of those and and are allowed to do their own determination on what they've already covered and what they need to add. Are SED tasks for predictive DSI required even if we are not a supplier of predictive DSI? Yes, they are. So there are the three categories of the SED tasks that we mentioned: evidence-based, as well as user-sourced predictive DSI, and then developer-supplied predictive DSI. So if the developer does not supply DSI, then the SED tasks, would not be appropriate. But they do need to look at risk patient safety for a user-supplied predictive DSI. So by enabling, creating a door, the user can select a predictive DSI on their own and use it on their own without developer assistance. So that functionality does need to be in place. When I last asked for a predictive DSI source company that is certified recommended to create the door to, I was told there is no certification for this. I'm still concerned as to how ONC can require adding AI functionality into EHRs without any governing body certifying those companies that provide it. Has this changed? Is there now a list of companies that are recommended to work with? Am I alone in my concern? Hope that this criteria will be pushed back. Okay, a couple things there. Has this changed? There aren't any third-party DSI providers that we can point you to at this point. Hoping that there will be some later this year. If there are any out there, we would love to know about them. But there is no DSI certification. I think that the way ONC has looked at that concern is by making those source attributes available that enable a user to evaluate whether it's faves, it was fair, accurate, valid, and things like that. So, I think it will be up to the user to determine if the PDSI is valid based on what it's in the source attributes. Am I alone in my concern? Hope that this criteria will be pushed back. No, you're not the only one that wants it to be pushed back, but ONC has not indicated a strong desire to do that. So I would not hold my breath for that one. You mentioned that for PDSI, all USCDI data must be made available. Yes, that's true. Can you clarify on this a bit? If PDSI does not use one of the data points, does not qualify. So the PDSI does not need to use all those data points, but the PDSI needs access to all of those data points in case it uses them. I hope that explains that better. We just want to double check on the guidance that PDSI does not suggest care, but does create a clinical note based on audio recordings between the clinician and patient. Does not constitute PDSI. The best information I have is that it does not. We're asking for clarification because ONC specifically calls out such technology in the final rule and names it PDSI. We can go back and check that, but my understanding was that something that does not use patient data and have some kind of create some kind of prediction would not be considered PDSI. Are you interpreting source attributes needing to be in plain language as just not in code, or do you have other expectations for plain language? So yeah, so plain language source attributes means not a yes or no. It means that the information is available to the user and not in coded form. So those demographics, source attributes, and a lot of the USCDI data elements are exchanged as structured data in coded format. Those coded formats are not useful to readable applications. And so ONC does not, has called out this plain language description to mean not provide just the code. So like if you're using the gender, you would say female instead of just F. Or if it was evaluating a medication, it would show the description, the text label for the medication, not just the LOINC code or RxNet code. If there is no certified third-party source of predictive DSI, how can a vendor who does not supply it do SED testing? That's a good question. I can't answer that. You know, we're hoping to find out about third parties that developers can connect to for predictive DSI. But at least for SED testing, you can do the parts up to and including the triggering. An earlier question, I believe clinical note is patient data when you're evaluating dictation transcription application. Oh, okay. I also understand predictive DSI to include administrative use cases, which included ambient AI scribing with no interventional output as in scope. but this sounds out of scope only now. How can we get confirmation of this? Are often off vehicle or delivery mechanism for predicting to reach users such as connections through clinic. Okay. Okay. I guess we can take a moment to look that up if there's no other questions. So. Large language. All right, so here's I can put a link in the chat or the comment. So this is the rule itself, and it says models that generate clinical notes or draft clinical notes and that were trained based on relationships in large data sets of free text, including large language models, and support decision making about what to document in the clinical notes would likely be considered predictive DSI. So if it is support decision making and documentation, then I could see that that would be a predictive DSI. So, but it does say generate clinical notes or draft clinical notes. So here's another one. This one says, so in the HCI1 proposed rule, we were explicit in describing the scope of our predictive DSI definition to include large language models or LLMs and other forms of generative AI that meet the definition of predictive DSI. We do not believe that LLMs should be excluded if it's used to support decision-making, nor do we believe that LLMs are black boxes about which no information can be made available to users that would be valuable. We agree with commenters that these would pose a risk if they are not deployed appropriately, and we believe that these requirements could help to decrease the likelihood that a model is inappropriately deployed. So we note that we have finalized the fundamentally limited the scope of B11 to focus on transparency and instances where predictive DSI, such as LLMs, are supplied by a developer of certified health IT and not generally on LLMs or generative AI that may be used in the healthcare ecosystem. So there is a distinction there. If it's used to support decision-making, then it would be. But other things that may be used in the healthcare ecosystem, let's say like something that determines if a patient will be a no-show, could be a DSI if there's a, if it meets those requirements of the definition. And if we could, Eric, if I could have you go back to the slide that has the definition of predictive DSI. There it is. Technology that supports decision-making based on algorithms or models that derive relationships from training data and then produces an output that results in prediction. So it would need to support decision-making. It would need to produce an output that results in prediction, classification, recommendation, evaluation, or analysis. So there's your definition. And if the AI or DSI system meets that definition, then it would be included as a predictive DSI. So yes, there is a distinction there. Any thoughts on how developers who don't supply DSI should receive PDSIs from doctors who self-develop the PDSI? That's the part about creating a door that would allow them to select. I don't have a visualization of what that would look like or a workflow of what that would be. But we can only suggest the G10 EHR provider launch functionality. With that, I think we've reached our time. And so thank you, and thank you, Eric and Brenda. That was a wonderful presentation, and I hope that you all found that useful. And if you have additional questions, as I mentioned, reach out and we'll set up a meeting.
Thank you, Brenda. Thank you, James. Thank you, Eric. Yeah, as James mentioned, if you have any other questions, you can reach out to your account manager or at the email on the screen or visit our website. I just want to shout out that our next webinar is on June 20th for AI in healthcare, and they will be touching on predictive DSIs again because, you know, it's an ongoing thing. So you can scan that QR code and register for the webinar. Thank you, everyone, for taking the time, and we look forward to seeing you at the next one.